Let us now move on to the next panel for the day. In recent years, companion diagnostics has emerged as a transformative tool in oncology, enabling clinicians to tailor treatments based on individual patient characteristics. This personalized approach holds the potential to significantly improve patient outcomes by ensuring that therapies are more targeted and effective. Today, we will delve into the current landscape of companion diagnostics, exploring their benefits, challenges, and the future outlook for personalized cancer care in oncology. And with this, let me introduce you all to the topic for this panel: Companion Diagnostics, Charting the Path to Personalized Cancer Care in Oncology. Now, allow me to welcome our panelists on stage. Dr. Vineet Talwar, Director, Department of Medical Oncology, Rajiv Gandhi Cancer and Research Institute, Delhi. Dr. Shyam Agarwal, Chairman and Director, Department of Oncology, Sir Gangaram Hospital, New Delhi. Dr. Bhuvan Chugh, Senior Consultant, Medical Oncology Cancer Care at Max Healthcare. Dr. Aparna Dhar, Director, Hereditary Precision Oncology and Genetic Counseling, Max Super Specialty Hospital. Dr. Jyoti Vadha, Vice Chairperson and HOD, Medical Oncology and Hematology Paras Hospitals. Dr. Reena Nakra, Principal Director, Lab Management and Technical Excellence, Dr. Lalpath Labs Limited. Now, I request Dr. Reena Nakra to please take over this session from here.
So, good morning, everyone. I think we all have a great segue from the previous discussions for this one. Companion diagnostics, paving a path for personalized medicine. What better than to have this group of senior panelists with us for this discussion. I'm sure this discussion is going to be extremely insightful. The first example, and I think it probably dates back like 40 years back, was PML RARA, where it actually came out that leukemia, which was so aggressive, did not have any good outcomes. Suddenly we had a marker which could be acted against, and it changed the path for medicine. So that's probably from there on, it's been revolutionary what has happened today. And with next generation sequencing coming in, we have like a plethora of kind of overwhelming plethora of markers, biomarkers available against which drugs can be targeted. And this is exactly what companion diagnostics is all about. It's a biomarker, a nucleic acid variation, whether it be in DNA or RNA, against which a therapy can be given. And or possibly it identifies patients whom these drugs would not be effective against, so spare them the side effects. It could also mean genetic carrier status. So all of this combined, is companion diagnostics. And I won't keep you further away from, the insightful discussions from the panel. I would like to, first ask Dr. Aparna on what kind of technologies are being used for companion diagnostics and today, and how do they differ, and what are the essential, requirements for these therapies? For the tests.
All right. So good evening. Good afternoon, everyone. So companion diagnostics essentially is a type of diagnostic test where we identify biomarkers that could have a potential influence in guiding therapeutic options for the medical oncologist. And there are different types of biomarkers that we look at depending on the solid tumor. So if you were looking for something like an EGFR, we know technologies that are available for this could be something like RT-PCR, where we use the COBAS method. There is your next generation sequencing. You could be looking for a KRAS mutation in colorectal cancers. Again, over here, you've got RT-PCR, you've got NGS, you've got HER2, something as simple as HER2 for colorectal and breast cancers, where we'd be using platforms like IHC and FISH. PDL1, which is again another very important biomarker. We use basic IHC, and then it depends which assay are we looking at. Are we looking at the DACO assay? Are we looking at the Ventana platform? So all of these are various platforms that are available, different technologies. What really sets it apart from our normal standard of care testing is that these particular assays have undergone regulatory testing where they've been validated with respect to their sensitivity and specificity of their results and how that actually influences your treatment options for your patients. So unlike the other standard of care where you go in and you just do a next generation sequencing or an RT-PCR, these have been pre-validated, and I think that's what really sets them apart. So a very classical example, if you look at it in our clinical practice, is foundation medicine, for example. Foundation, the solid or the tumor panel is very well validated and actually recommended by FDA for a host of different solid tumors like your biliary tract cancers, your gastric cancers, your lung cancer. You've got the Myriad germline platform, which is actually validated, and the recommended companion diagnostic for germline BRCA testing, or their Myriad's HRD testing in the case of ovarian cancers. Basic simple ones, some of Thermo Fisher's assays are also FDA approved and are known companion diagnostics. So these are pre-validated assays which kind of just increases the sensitivity and specificity in calling out these particular biomarkers.
Yeah, thank you. I think, one of the essential characterization of companion diagnostics is to not only prove that you can reproducibly measure it, so that requires that analytical validation, but also the context or the clinical context that you can use it in needs to get validated. And with that, actually, I would like Dr. Shyam Agarwal to tell us about how we can use, certain, like we do have a lot of complex cancers with very complex molecular profiling, and how do we tailor therapy for such profiles?
Yeah, right. So thank you, VOH, for inviting us here for this panel. So, actually, if you have to look at cancers in terms of being driven by oncogenes, so one can have actually two extremes. One extreme is a cancer patient whose tumor cells are addicted to one oncogene. And we have several examples of those. And I think you named PML, but I think more important than that, which is more common, is chronic myelogenous leukemia, where the journey started, with the precision personalized medicine by detecting the BCR-ABL gene aberration. And we have, in India itself, more than 30, 40, 50,000 patients who are taking the benefit by just doing this simple test. And then on the same lines, we have the poster boy lung cancer today, where we have at least 10 genes which we can identify and target them, because these cancers are addicted to that particular gene. And that is why when you give them one pill, 70, 80, 90% of the patients respond. But then the spectrum starts changing. The CML patient, for example, just given a pill, goes on for 20, 30 years. Whereas when we come to lung cancer, where we have different gene aberrations, you give that pill, a person is only going on for 10, 12, 19 months, and then the patient is progressing, indicating that the tumor evolves and develops either mutations in the same gene and therefore becomes resistant, or acquires a new mutation or a new gene aberration, and the cells, they start dividing, and then you address that by doing the NGS, and you can perhaps change. So, by and large, cancers are very complex. So, we are not talking about common cancers as they exist in our society. For example, head and neck cancer, cervical cancer, these are common cancers in our setup, in our country. And where is the targeted therapy? Where is that precise gene for those cancers? We don't have. So, what we have in most of the cancers is a complex genetic mechanism in which you may have 90 or 100 genes which are gradually become abnormal, And there are, out of those 100 or so, 9, 10, 7, 8 are the driver oncogenes. So those driver oncogenes today, with the available technology, you put the tumor tissue into the machine, you get that information. P53, PIK3C, you name those, CCD and KA, etc., etc. But where are the drugs to target them? So this technology currently is applicable to a minority of cancers whose genes we can identify, and then we have the drug available, and they should be addicted to that particular oncogene. So unfortunately, we don't have drugs. We understand P53, we understand KRAS, we understand NRAS, but we don't have drugs at the moment. So these are two extremes, as I was just started my conversation with. On one hand, you have an oncogene addicted cancer, but majority of the cancers are not addicted to one gene, and then you need to identify those drugs. So this is work in progress at this point in time. Yes, of course, in terms of technology, I mean, you do have comprehensive genomic profiling, which can now identify DNA, RNA fusions, etc. So you have that ability now. I think it was very heartening to know from the previous session that from 2.5 lakhs, they want to bring down the cost to 10,000 or even lower. But then I think the pharma industry, the researchers, the institutions need to work on developing newer agents to target those aberrations which we identify in common cancers. Thank you.
Thank you so much. I think that's a very important point because, like the tumor heterogeneity, the kind of responses the tumor itself will make and change because it also wants to survive. So, that itself causes like our ammunition in terms of drugs, we fall short of. But I would like to take thoughts from Dr. Vineet Talwar on, his experience in, say, genitourinary cancers and prostate cancer.
Taking cue from what Dr. Shyam has said, I'll take it a bit further. When you talk of, say, prostate cancer, typically in an advanced prostate cancer, you have a hormone-sensitive era in which patient goes on for about 3 to 5 years. And once the patient becomes hormone refractory, that is a castrate-resistant setting, that is the time when the survival just collapses. It is about 1 to 1.5 years. So that is the arena where you can, think of newer modalities, out-of-box thinking, precision medicine. And there only you have certain genes like BRCA1, BRCA2, you have CHEK, all these things are there which can be targeted. So initially when we used to treat, I am a medical oncologist, we used to treat, we used to give hormones, patient used to become refractory, we used to give chemotherapy, and that's it. Now we have these genes which can be targeted, and once you can identify these onco drivers, then you can just cut the vicious circle and lead to cell death, the cancer cell death. So when you target these with the PARP inhibitors, you are able to garner about 14 to 17% of the actual population which is there in the hormone refractory area. And apart from that, you have other things like MSI, which can target the immunotherapy, which can, with immunotherapy drugs, they can. So on a pie of 100, you are able to garner about 30% cases, which were not there. You were bereft of that treatment earlier. So run of the mill, you give hormone treatment, you give chemo and you stop, but now the vista is wide open. And apart from that, you have other genes also which may have some relevance in times to come, but as of now, we are just able to make out, yes, this aberration is there, but how to drug it, how to bring it about, that still remains a challenge. One more thing I would like to say is, one is that you have a test. You have a lot of companies nowadays which are doing these methodologies, but then the validation also is very, very important, because the interpretation is one, the validation is another, to make it more robust so that you can, give the appropriate drug against it with a lot of confidence.
Thank you, Dr. Vineet. I think that's That's very, very important, and it's one of the hurdles that or the challenges that we today face in companion diagnostics. That's the entire validation process, the regulatory process, and the development of the drug alongside, which is taking so much time to come to the market and to the patients because we do need it to be developed. Hopefully, with technologies like AI, and we would be able to actually fast track those clinical trials so that we have these much more available. Dr. Jyoti, I would like to take your thoughts on, what promising results have you seen with certain cancers, and what has been, the success drivers for them?
So, the comprehensive genomic profiling, or NGS, or precision oncology, or companion diagnostics, they have really changed the way we medical oncologists now treat a cancer patient. So, unlike, say, 2 decades ago, when it was just limited to the type of cancer cell which we saw under the microscope, the times have moved, times have changed. We now characterize the tumors at molecular levels. So that's what the basis of precision medicine or precision oncology. And therefore, say lung cancer is no longer just divided into small and non-small cell lung cancer. We have gone much ahead. So non-small cell, further subtype, and then further molecular subtypes. We know there are many molecular subtypes of non-small cell lung cancer. And therefore, we are talking of precise treatment for a given patient for that precise type of tumor. So the cancers which are common, such as lung cancer, breast cancer, colon cancer, they are being treated as per the reports of NGS or CGP now. So what we have seen that especially in these common cancers wherein we are now offering precise treatments, the outcomes have improved. It is very well documented that, say, for lung cancer, the survival based on the decisions when they are based on precision medicine, the survival of these patients is much superior, many months more than what would have happened otherwise. Similarly, in breast cancer, and so on and so forth, colon cancer. So, say for example, in lung cancer, there are multiple, Dr. Shyam Agarwal said there are at least 10 treatment options available based on the driver mutations, and wherein we have seen that these targeted treatments work much better than the chemotherapy which used to be the standard of care, say till 2009. But now the patients are living much longer because of these targeted therapies, and they are living much better. So the not only has the survival changed, but the quality of life is also much better compared to the earlier times when we used to practice one size fits all. So that's no longer the case. Similarly, say in colon cancer. So it's not only important to identify that driver mutation wherein we offer the targeted treatment, it's also very important to identify an alteration based on which you would not offer a treatment. Say, for example, in colon cancer, if you identify a RAS mutation, you know that the anti-EGFR therapy would be futile. Such a patient, the tumor would be resistant to it. So you would not offer. So it also tells us what not to do in a given case. Subsequently, we know tumors outsmart the treatment and they evolve resistance mechanisms. So the other beauty of these tests is that we can know the resistance mechanism, and therefore offer the better treatment to such patients during the course of the illness. Say, for example, in lung cancer, if we identify T790M, so we offer, osimertinib. And similarly, we have others. Say in breast cancer, we know, presence of certain genetic alterations wherein we have specific drugs which should be offered. So similarly, these are the common cancers. The advances in companion diagnostics and precision medicines have also changed our outlook towards rare cancers. So wherein there is no standard of treatment till very recently, there wasn't any. We now have some direction whereby we could test with the companion diagnostics and offer the right treatment to a given patient. So that's another advance which I think has happened over the years. So a lot of change leading to paradigm shift in the cancer treatment has really happened over the years, and the results are much better. much superior. And as I said, not only the improved survival, but also the quality of life.
Yeah, I totally agree. And I think with these technologies, and especially with NGS, while it makes life simpler, it also, on the other hand, kind of gives an additional complexity, because you could come and identify 2, 3 driver mutations which are there, and each having a separate targeted therapy. And then, what do you choose and how do you choose? And I think I'll ask Dr. Bhuvan, like, how would you approach such genomic complexity in cancers, and what are the challenges that you would face as a clinician?
Thank you, VH, for inviting, and thank you, Dr. Nagra, for that question. So, I think in last 5 years, we are getting more and more access to the genomic reports. Obviously, as you said, the complexity has increased significantly. But then, I think it's been, for me personally, it has been a journey of a learning in the last 5 years. In the first time, when you get an NGS report, it used to scare me as an individual. How would you read about the genomics or the different mutations which are there? How would I interpret those mutations? What sense do I make out of them? So probably, as they say, it takes a village to raise a kid. I think it takes a village to read an NGS report also. So I would reach out to most of my genomic friends and give them a call as to understand what is there, and they would tell me the report, and I'd say, I don't want to know the report, I want to know how did you make sense of it. I think that's where the learning started to come in, that what each mutation means, what pathway is it driving, how that pathway is interacting with the other mutation which is there, how do I make sense of this report. And that's the inquisitiveness which was required, which is still required rather. So as and when we kept reading the reports, I think now I've reached a place where I'm excited when I get the next NGS report, because I'm able to make sense of almost 70% of it. I'm not saying that I'll ever be there 100%. I think it's a constantly evolving field. There is a new mutation which is added every day. One of my favorite question to my genomic friends were, is there a book I can read? They would always come back and say, no, there is nothing you can read about it. It has to be, each report has to be curated in a way that has to take in the clinical history. You have to tell me the background of the patient. You'll have to tell me where all is the disease. Why did you get this done? So each individual report it's a challenge in itself when you take in the patient there. So obviously for them also, when you share the report to them, they do not give you an answer right there. They also need to look at it the way you probably would have looked at it. So now each time when I get a report, I generally, we have Dr. Parnar, she's in-house to us. We obviously utilize her vast resources which she has and information which she has. Otherwise, I do reach out to the companies which I'm sending the genomic reports to. I do take a second opinion from there. I generally deep dive into the mutation reports at myself also, because that's the learning which I want to have. You go on the ClinVars, you go on the OncoKBs, you go. So most of these websites are bookmarked for me now. I would feed in the particular mutation which is there to read how do they interact with each other, and then you form an opinion of it, which possibly is given to the patient. So there is no easy answer. Sadly, I have not been able to find an easy answer to reading an NGS report as yet. However, yes, I've reached from a place of fear to excitement in the last 5 years with each NGS report, and I think that's been my journey. And I rather like it than I have a new NGS report, because give me something else to do for the next 4-5 hours and dig deep into it. And now the last patient I had, and when I had a foundation report, I did call up Arun. I said, before you interpret it, let me interpret it to you. Let me give me my brief. If you have something to add on, you tell me that. So I kind of reached 90% of what he would have to say, and then the 10% he added on. So I think that's been my journey, and that's possibly, I think, I do it.
Yeah, that's a wonderful perspective, because exactly like how I think all of us are learning on the lab side too. We face this challenge of how to put it across in the most meaningful way for the patient, because sometimes the information we put out, we also struggle with trying to prioritize it and say exactly how it should be read. And I would probably ask Dr. Aparna, since you work closely with Dr. Bhuvan, as to how do you, what solutions do you think could address these challenges, as well as how further, any choice of the diagnostics, can we put it on the report, or how do we go about doing that?
I think one of the key, if I could start off with challenge and then come to the solution, is that there are a lot of laboratories in our country who are service providers, and you just see the variation across the next generation sequencing reports that come, be it CGP, be it even at one of those small hotspot panels, tumor specific panels. So for us who are supposed to understand these reports, it's sometimes very daunting. Even a simple 12 gene report becomes daunting just because of the layout of the report or the type of technology that has been used, or sometimes you don't even understand what they've done and what they've reported just by a simple 12-page report. So I think it first has to start with standardization of reports. What methodology are you using? What classification methods? So we know that when we're doing tumor profiling, somatic testing, classification has to be based on AMP. However, today I see a lot of somatic reports where ACMG is being used, that because ACMG, which is for germline, is positive, so by default in somatic it's positive. That's very incorrect and very misleading. So I think we need to start with that. And one of the key ways of finding a solution for this, at least in our clinical practice, is just like Dr. Bhuvan said, having conversations. And these conversations are between geneticists, molecular biologists, pathologists, radiologists, medical oncologists, surgical. When we talk about precision oncology, it's not just about an NGS report. It's actually being precise in what treatment option you choose for your patient. So having a conversation, getting a 360 view of what exactly is the issue at hand and what is the most best approach with the best outcome for your patient, I think that becomes extremely critical, especially when you're interpreting these reports, because it gives a lot of information. Sometimes that information is telling you, don't do chemotherapy, don't do immunotherapy, don't do targeted therapy. What do? You've got a report that's just going on telling you bad prognosis. So it becomes, I think, starting with a molecular tumor board, a multidisciplinary approach where everyone is there, all the stakeholders are there making decisions, becomes extremely important. Second, I think it boils down to the laboratory. In the laboratories, I think we have to have some sort of a guideline, while everyone says we're NABL and CAP, but honestly, you have to go back and look at the validation data. We are seeing a lacunae in that area, that you could have one of these, you could have something like TheraScreen for PIK3CA. This is a companion diagnostics test, but are all the labs actually running the assay as is supposed to run it? Are they using the right limit of detection? So you're getting a lot of false positives and false negatives. So to reduce the errors, we need to form a standardization protocol across all our domestic partners. So when you have those sort of assays, it's amazing to hear that you're going to get CGP at around 10,000 rupees. That's brilliant. You're kind of giving that access to all your patients. But what would be the validation for that? The reason today a Foundation, a Guardant, a Tempest has become so popular, and our physicians are gravitating towards it, where the financial toxicity doesn't affect an individual, a patient. And that's because we know there's standardization protocols, and that's something that we have to implement. When that's implemented, I think with having conversations, having that implementation, and actually educating each other. It's not a one-sided thing that because I'm trained in molecular biology, so I know it all. No, it's not that. It's when we start having conversations with medical oncologists, you start understanding the clinical aspect, you incorporate that with the molecular aspect, the genetics aspect. That's what works and kind of gives you the best interpretation. So educating one another in understanding the medical and the NGS part of it, I think these are some ways we can actually overcome these challenges. Talk to one, talk to two, talk to three people. You'll be amazed as to what you learn with every case, because every case is unique, every case is different, even though sometimes the molecular profile is the same. But because of the patient's response to certain types of therapy, the way you'll interpret is different. So I think for me, these are ways how we overcome our
I think taking off from your last point, it also always has to have a clinical context and not just, I think while each lab obviously has, and most of these tests are lab developed tests because, except for foundation medicine, which is FDA approved, most of these do not have approvals, and those processes are still on. They also take in a lot of costs. But given that, standardization is important. Obviously, like tumor boards, multidisciplinary teams addressing these reports is extremely important. And I would like Dr. Shyam Agarwal to, talk about how clinical context becomes important and what
Right.
outcomes, he sees.
So I think Dr. Bhuvan and Dr. Aparna, raised those points. We are getting flooded with the information on the genetic aberrations present in a particular tumor type. And if, for example, you have 3, 4, or 5 gene mutations or deletions or whatever, and then you have 5 drugs which are identified individually for those. So what does the clinician do? I mean, we believe in practicing evidence-based medicine. Evidence-based medicine means that there has to be an approval for a particular drug or a combination of drugs which are being given to an individual. So here, in the light of that genomic data, you have 5 drugs which one can use to target those 5 genes which have been found to be abnormal in that particular tumor. But there is no existing data as to how much dose and how to combine those 5 agents. So on the other side, you have a patient who is wanting to get well and is showing you a report. I mean, doctor, you have those 5 drugs. Why don't you give me all 5 of them? The problem of the clinician is that if I combine all 5 of them, because they have not been tried earlier on, he may have a side effect from the combination of those 5 agents. And then what does the doctor do? So I mean, that is a huge dilemma which I've been facing ever since you're getting these, complex multi-gene abnormalities reports as to how to, address that. There are a few studies where people have given in second line or first line therapy those combination of drugs, giving them half the dose for VEGF inhibitors or TKIs and so on. But those are so which means that we really need to explain all this to the patient when you are entering into an experimental field and you're doing that experiment live on the patient. If the patient succumbs to the side effects of that combination, I mean, where does the doctor go? So I think that's a huge issue to my mind when we are facing these scenarios. And I understand that if patient has exhausted all the existing lines of treatment, perhaps you have to document that, and patient family has to be explained in great details that there is no proven efficacy of this particular combination. So you be careful and give us your consent that if something goes wrong due to the drugs, I mean, the doctor should not be held responsible. So I think that is one thing, which to my mind in our practice, which I face, and I really fear if somebody has a, downside from the combination of drugs which we give to him or her, depending upon the, the gene reports. So other than that, once you have an approved indication of a single drug against that particular gene, I think we're very happy to use it, and I think that has really changed the the lives of patients suffering with a variety of cancers, whether it is lung cancer or breast cancer or colon cancer, and name it. I think I mean, you have more than 200 types of genetic aberrations and drugs available today, which have got the approval from FDA and NCCN and DCGI. So which we are currently using as per the guidelines. So when you have to go beyond the guidelines, that is where the whole, the problem starts. And that is where utmost caution and the conviction of the doctor and of course the family has to be, taken into factor.
Thank you. While we discuss a lot of complex markers and many markers. On the other hand, we have possibly markers which are pan-cancer or which are agnostic of the tumor. And I would like to ask Dr. Vineet on his thoughts on agnostic tumor markers and how to approach therapy.
So, madam, this is like putting the spanner in the works. You have a big array of genes and targets and interpretations and misinterpretations and clinical validations. So here you have one size which fits all. You have an agnostic marker. Agnostic means I don't know, I don't care whichever is the organ of origin, but I will work. If you have that marker in that organ, irrespective, initially whenever we used to give chemotherapy, we used to see that, okay, breast cancer, so this is the protocol. Say pancreas cancer, this is the protocol. So here you have one marker, say microsatellite instability. If you have that marker, well, irrespective of the organ, you can give that drug, that is the immunotherapy drug, which got the registration trial approval. And it works in some percentage of cases, mind you, not all, some percentage of cases, but it works. So now question is, where do you apply it? During the paradigm of treatment, whenever you find that the patient has undergone, multiple sets of treatment, standard treatment, then probably you can bring it in vogue. But that was when it was about 4 or 5 years back. As a natural history of drug is there, it climbs from multiple lines, metastatic setting, it goes to the adjuvant setting and then the neoadjuvant setting. So now, say for example, colorectal cancer, if you have this marker, then you can give it initially only and get the same benefit as compared to the standard chemotherapy drugs, albeit at a very, very minimal morbidity. So at about say 10% morbidity, you can have the same effect. But again, there is a caveat. These are new drugs. They have their intellectual property rights coverage. So finance remains a big problem. And India, as all of us know, is a price sensitive market. There you have to mix and match everything and use your clinical and financial discretion when you discuss with the patient. Because as a clinician, this is the last thing that I want, that I tell the patient that this is the drug, it will work in you, but just because you don't have the finances, you will not get the benefit. So you have to, create a middle of the road path and then proceed.
Yeah, I think that's one big dilemma that the clinicians face. And Dr. Jyoti, I would like to, take your thoughts on how do you use these companion diagnostics for tailoring therapy or making these treatment decisions?
So I think it has been pointed out more recently by Dr. Shyam Agarwal. So it can be confusing also. So the main aim is to offer the right treatment to the right patient at right time, right? And in right dose also. Let's start with a case which is not confusing. When, in fact, we have levels. As per the guidelines, if we follow, we have different levels of evidence. So level 1, 2, 3, and A and B, further subcategories of A and B, wherein based on a companion diagnostic, we have a standard biomarker, we have a standard indication, and it's approved based on the evidence. If we start moving down, that's level 1. So if we come down, there's a standard drug, standard biomarker for another indication, a biomarker which is not yet so well standardized for some indications. So there are different grades, different levels, and it would obviously be the best and safest for a medical oncologist to always go in with the tier 1 or level 1. But that's not always possible. So therefore, then we have to extrapolate from an approved standard indication to another indication, depending on how, how much the prior treatments have failed, what is the gravity of the patient's situation, condition, and how desperate we are. So I think those factors also need to be taken into consideration, because if we have run out of all the available standard treatment options, then we do explain to the patients that these are the options, these are possibilities based on this level of evidence, and therefore this is what we could offer. And obviously the patient has to understand and say yes to all pros and cons of that treatment, and only then proceed, and that we have to document and then only start. And similarly, as Dr. Vineet was saying, that tumor agnostic, so there also we have more than one. Now we have different tests which are, and there are tumor agnostic markers, and based on that, and there are more than there are 5-6 of them, based on which, irrespective of the tumor site, we are it's legal and it's evidence based to offer those particular treatments. So he mentioned MSI, similarly tumor mutation burden, or RET mutation, or some more are there. So we could offer. So those are also approved. So I would, in my practice, go by the level of evidence, both for the marker and the given indication, and then weigh the risks and benefits, and then offer. So that's what I do.
Yeah, I think Dr. Bhuvan, anything you would like to add to how you would use companion diagnostics and kind of avoid the cost for the patient, or probably down the line it would become cost effective to use companion diagnostics, and how would you address this whole sphere of a lot of drugs, biomarkers or agnostic markers, and the therapies available?
So I completely agree with Dr. Jyoti when she says that the patient's benefit and the level of evidence has to be factored in. You can't be experimental. You have to be empathetic when you are speaking to the patient. Your level of evidences have to be factored in. We all broadly agree that the first rule is do no harm. And if there is a drug or there is a line of therapy which has been proven in that particular setting to have a better objective response, stick to it. I think most of us, we may choose to run a companion diagnostics early on, but when do we choose to bring it in the treatment paradigm broadly depends upon when the patient starts failing the proven line of therapies. When they have failed the first line or the second line, which we have a level 1 of evidence, which when they start failing it, that's when we try to bring in this genomics reports there. If you have, I had a triple negative who barely went with 2 weeks with taxanes and then another 2-3 weeks with anthracyclines. So, these are the patients you would want to bring in the genomic report sooner, because the patient is failing and I really need to bring in a drug which needs to stop this catastrophe happening. So that's when you need to have a conversation with the patient that essentially in a language or in a way they understand best. You share the information with them, understand how they read it best. If they are auditory learners, or if they want to be shared the articles, give them those articles. Let them understand that this is a lacuna which you are treating with. They have a disease which is fairly difficult to treat, which is is going to be taking away their life. If you're not going to do something about it, give them information and then give them time to go through those informations and let them come back to you about what they think, what you have said. And I think it's a very partnered decision making which tend to happens at that particular setting, that most of patients which come to us, they have a difficult disease. You have a breast cancer who have exactly 5 bone mets, upfront 29-year-old lady. You can't tell her that this is going to be the end of your life. You eventually have to find a solution. That's what they've come to you for. So you sit across the table with them, you tell them this is what the disease which is there, this is the data which I have, we can run a genomics report here, we can see what extra can be done, this is the level of evidence which I can provide you there. And then you utilize that entire information and form a decision and tell them, please take your time. You want to take a second opinion about it, go ahead. I think we're all peers here. I'm sure if you go to person X, they're going to call me and we can have a better outcome for you. I think that's what we deserve, that's what they deserve, and that's what we also, it's our duty to provide every individual coming into us with that particular set of information which is the best applicable to them. Right? So there'll never be one size fits all. It'll always be in your head rationalizing, am I doing best for them? Is there something else which can be done which is better than it? Is there something established which can be done which is best for them? If there is, keep this aside. However, if there is not, please bring in a companion diagnostics, have a discussion with your peers, have a conversation. You speak to 5 people, you will be able to eventually form an opinion which will be the best opinion for the patient. That's what I do.
Yeah, I think lovely thought, and I really like that because, as the name suggests, like companion diagnostics is all about the diagnostic in partnership with the drug, and I think we need to extend it further when we say like it's not only personalized, also we have the patient partnering with us and being a part of that decision as to how do we best use the therapies available for that patient. Hopefully, like diagnostics, the technologies that are coming in, and with a lot of the use of AI for clinical trials, we'll be able to fast expedite and kind of bring in more evidence so that they can be used. We could probably bring down the cost so that it doesn't become so difficult to try these medicines with the patients, or even the tests can come in probably early on so that downstream costs for the patient become lesser in terms of therapy and as well as tests. So with that, I thank all the panelists for contributing to such a wonderful discussion. We have a minute and a half, so in case the audience has any questions for the panelists, I think we can take that. Anybody? Right. So we can conclude. Thank you so much, and wonderful having this panel.
I'd like to thank our panelists for such an informative session. I'd like to thank Dr. Nakra for wonderfully leading this discussion. Now I request Dr. Nakra to please felicitate her co-panelists. Dr. Vineet Talwar, Dr. Shyam Agarwal, Dr. Bhuvan Chok, Dr. Aparna Dhar, Dr. Jyoti Vadhva. Now I'd like to request Dr. Manisha Khurana to felicitate Dr. Reena Nakra. Dr. Reena Nakra. Now I request the dignitaries to please step forward for a group picture.